Thanks. So to begin with, this work will not be possible without all the effort from the rest of the team. So it was a combination of researchers and also a couple of community members, both Samira and Zara, who played an integral role in helping with recruitment and co-facilitation, were also co-authors in this paper. So to begin with, who are underserved communities as such, and why do we focus on these groups? So thinking about it from a UK perspective, so first of all, there is something called as the NIHR Include project. So this mainly focuses on people who are underserved in research, and it mainly depends on different contexts really in terms of who underserved groups can be. And it also sometimes is based on, lower inclusion of research, and it depends on various protected characteristics. So usually people from underserved groups tend to have higher healthcare burden, which is not necessarily reflected in the research work that takes place. And there are important differences in how groups engage or respond to healthcare interventions as such. So underserved communities, as we all know very well, also experience health inequalities. So this can be due to, or there are a variety of reasons really. So one, it's to do with demographic, socioeconomic, and also health-related factors as well. And you also have, ethnicity, which plays a predominant role. So people from ethnic minority groups are one such underserved community, if you like. These groups also tend to have inadequate access to primary care and barriers in accessing care itself. And lack of diversity in research often tends to mean that there is limited relevance and generalizability of study findings. So one of the things that this particular study concluded, the Include project concluded, was that there was a need for stronger community engagement to ensure that there is a shift in focus in terms of priorities from research happening that is mainly focused on researcher-led approaches to more community-led approaches, including research priorities that are co-designed with communities as such. So thinking about that, what we did was for our study, we used a methodology, participatory methodology called World Café. It's essentially a very informal, but also a very flexible approach that encourages conversation amongst participants. World Café has a toolkit that is freely available. You can follow the link to the website that you can see on the screen, and it gives you a clear outline in terms of what the different steps and processes are. Essentially, what you try and do as part of World Café is that you try and set it up in a very informal cafe-style environment, preferably in a community setting, so that people are more familiar to that area rather than expecting them to come to the university, which can be perceived as more of a threatening and unfamiliar environment as such. You start out with welcome and introduction. Typically, what you do with World Cafés is that per round, you have one question that you ask the group. And typically, the rounds last between 15 to 20 minutes or so. And at the end of each round, some people switch tables. So this essentially allows you for cross-pollination of research ideas as such. The other advantage of using a methodology called World Café is also that when you do have people who are not necessarily proficient in English or require language-related support, what you can do is, rather than people swapping tables, you can ensure that your notes are swapped across tables really. So in these situations, what you do is you have language concordant facilitator and scribe at the table so that you can have discussion simultaneously happening in different languages as well. And then towards the end of all the discussions, what you do is that it focuses on something called as, sharing of collective discoveries as such. So this essentially includes sharing conversations with wider groups and often might include some sort of visual representation as well. So thinking about how we developed the questions and also the focus of the discussions really. So prior to each of the sessions, what we did was we worked with people from different communities to decide how best to run the sessions. And one of the things that, the group suggested to us was that because of cultural factors, they thought it was best that we ran sessions separately for both men and women. So as a result of this, what we did was we ran a separate session for women mainly from Black African and Caribbean backgrounds. Few South Asian women and East Asian women attended the discussion as well. And the topic area that they chose was focusing specifically on supporting mental health and well-being. With the men, we mainly worked with Somali men as such in and around in Bristol, and we talked about prostate cancer, specifically also to do with primary care services as well. So with the members of these groups, what we did was we also identified questions that we should be discussing as part of these two sessions as such, and also had some idea and indication in terms of how best to recruit people from the communities for the two World Cafe sessions, and also supporting some of the people to help facilitate the discussions on the day as well. And a key thing to note is that we ensured that everyone was reimbursed sufficiently for their time. So within the UK, we have something called as the National Institute for Health and Care Research, who is our main funder, similar to your CIHR in Canada. So they have a specific amount that you are expected to pay on an hourly basis to public contributors or patient partners, which is £25 per hour. So that's the amount we ensure that we paid everyone. So in terms of the questions as such, you can see that these are the three questions that we mainly co-developed with our community partners as such for the women's discussion. I'm not going to go through all the questions as such. I'm just going to let you have a look at it. And then for the men's session, these are the three questions that we identified specifically from an accessing primary care perspective as well in relation to prostate cancer. So in terms of where and who as such, you can see that what we did was we ran the session in a community setting. You can see that both the sessions were very well attended, with 24 women attending the session on support for mental health and 22 men attending the session for prostate cancer. The Women's World Cafe session, we also had the opportunity to record it only because we wanted to ensure that, we didn't lose out on any of the key or crucial points really. So this was just to mainly allow us to go back, check that we have recorded all the information correctly and accurately and nothing was lost in translation. With men's session, we would have preferred to do this. However, because of the nature of the topic area and predominantly because they hadn't even talked about prostate cancer amongst themselves or even with their family members, we decided against recording these discussions. So this meant that there was a lot of clarifying and then note-taking as well. So we ensured that there were at least two of us at each table to make notes. That way we weren't missing out on any of the key and important discussions. As I've already mentioned, Zara and Samira helped and supported us with recruitment, and all the public contributors who participated and facilitated in the sessions were paid. So during both sessions, what we did was we had community participants sit in small groups. We worked through 3 questions. Each question or each round lasted for about 20 minutes or so, and these were facilitated by public contributors. Our role mainly was that of a scribe, and we only intervened if we required clarification, really. Otherwise, we just sat back and observed the discussions as such. Questions and discussions in English were also translated into their relevant mother tongue. So in some cases, it was Somali. In other cases, it was in either a South Asian or an East Asian language. So in this case, it was in Bengali and in Chinese as well. But there weren't very many people, though, who couldn't communicate. So this was mainly having another individual who, who was there to support them with language as such, rather than doing that translation for the whole table, if you like. And then men's session, we mainly conducted in Somali as such. And as I've already mentioned to you, in terms of audio recording as well. So here are a couple of photos from the discussions. So we also ensured that we secured their permission to take and use these pictures, mainly in presentations or other discussions as such. We wouldn't, those who were uncomfortable, we ensured that we didn't take any photos of that table, or we did it from behind so that they weren't necessarily recognized as such. So post-event, what we did was we wrote up all the discussions and listened and reviewed to the audio recordings as well, and organized them into key categories as such. And what we also did was we produced a visual storyboard for each of those discussions, really, or World Cafés, so that it was something done in a very accessible format, and it was easy to understand and also capture at the same time, really. So it served 2 purposes. One, it was shared in a very accessible format for the public contributors who took part in the World Cafés. 2, it also acted as a visual representation to capture all the discussions as such. So I'm just going to quickly share a couple more slides with you. So from the 3 questions, you can see that some of the things that came about with the women's discussion was mainly around need for specialist roles as such to act as a bridge between the community and healthcare services as such. And there was also a need for changes to healthcare provision and the way it was undertaken as such. Women also felt that it was quite important that healthcare professionals took a more, family members took more of a proactive approach so that they are able to support them. So this was mainly in relation to, for example, healthcare professionals not necessarily wanting to discuss patients' health with the family members. And this meant that family members felt as if they weren't adequately equipped to then support their loved one. Similarly, education, information, and communication was quite vital as such. And lastly, there was a need for more individualized, personalized care and improved support services so that people can access it better. So hopefully you should be able to now see the visual representation from these discussions. Ideally, if funding had permitted and time had permitted, what we would have done is had these translated as well into Somali and other languages. However, we were unable to do so. So one thing that I didn't mention was we literally had funding for 6 months, and within a space of 6 months, had to undertake all this work as such. So I'm just going to have this on the screen for another minute or so that you can take a look to see what some of the discussions focused on. So from the men's session as such, so you can see that there was quite a bit of confusion, specifically when men visited GPs for urinary or prostate-related problems or issues. But it was evident that there was quite a lot of confusion around the diagnosis and treatment side of things, although this wasn't necessarily universal. They often talked about their trust in GPs and specialists as well for dealing with prostate-related issues. For them, the other aspect as well was mainly from a cultural perspective. It was important that they saw a male GP rather than a female GP when it came for prostate examinations as such. This was mainly due to embarrassment due to the nature of the condition as such and the examination mainly. From a pharmacist perspective, what was really interesting was people didn't necessarily understand the role of pharmacists as such. So this was predominantly because the way they perceive pharmacist's role was more that as a dispenser of medications rather than someone who they could go to for advice and support as such. Similarly, because of the nature of the condition, they didn't feel necessarily comfortable talking or discussing about, prostate cancer or even prostate-related issues to both families and friends. Similarly, long waiting times was a barrier to accessing GP services. Apart from that, language was an issue, and so was technology as well. So for example, trying to make online appointments, so going through the online booking system wasn't necessarily the most straightforward one. So you can see here, these are some of the discussions again from the men's session. So quite a few people actually talked about going abroad as well for treatment, either because they couldn't access services here or because of the slow nature of the services that was provided to them. Sometimes there was a lot more worry and concern, and they felt like they weren't necessarily taken seriously. As a result, they preferred doing this instead. So in terms of identifying priorities, as you can see, there are some overlapping priorities across the two groups as such. So this mainly focuses on a need to improve healthcare services, and that includes adapting communication, information, and signposting about services to ensure that they are accessible and at the same time applicable to different communities as such. There were also long waiting times for seeking appointments, choice in terms of who provided care and treatment. So this was often, anticipating that someone from an ethnic minority background rather than someone who necessarily spoke their language, for instance. So sometimes, coming from the same background in terms of someone who looked like them mattered as well. Continuity of care was something that was very important to both these groups. And it also had significance to do with building and establishing long-term trusting relationships with healthcare professionals, which in turn meant that there was better understanding of their clinical issues and awareness of what problems they had, essentially their medical history, really. So in terms of lessons learned as such, so adapting existing participatory researchers, approaches can add value to research prioritization exercises. As far as we are aware, this was the first World Cafe workshop to be undertaken in the UK, focusing on primary care research priorities for diverse communities. Similarly, community leaders can play a key role both in terms of co-delivering workshops, but also in terms of facilitating the discussions in different languages and also recruiting participants as such. World Cafe is also quite effective in engaging with diverse communities in research discussions. and that it is actually possible to identify important priorities across multiple workshops and areas using this sort of approach. And however, one main limitation, if you like, was that we didn't conduct any formal evaluation as such of the process from the perspective of participants to understand what worked well, what could be improved or done differently for future World Cafés as such. The other thing to bear in mind is typically with World Cafés, one of the things that we could have done would have been to do some sort of prioritization at the end by asking people to use like colored dots to rank priorities as such. But with the groups, it was tricky and challenging to get them all in the same space to then have those conversations. And very honestly speaking, once people were open and started engaging in those conversations, it was really hard to get them to just pause and do anything else but engage in those discussions. So as a result, we didn't do that. Therefore, it's more of an agenda setting exercise as well, if you like. So in terms of moving forward as such, one of the things we are currently doing is looking to see if we can have healthcare professional come in and deliver an information session about prostate cancer. We have been trying to sort this out for sadly a year now. Unfortunately, the clinician whom we are trying to get has been super busy with competing priorities. We haven't managed to do this. However, what we have managed is to ensure that the communities have got access to other events to do with prostate cancer, etc., which have been run in their local communities. So we have been ensuring that we signpost people to that so that they are still getting some sort of information as such. We have been trying to seek for additional funding to co-create some informative videos about mental health and well-being with the communities with whom we did the Women's World Cafe session with. However, the university-related funding we applied for, we were unsuccessful, so we are currently in process of looking out for additional funding. The reason why we thought videos would be a good idea is because this is what the women came up with, and that's what they wanted. And lastly, what we are also doing is we are organizing a patient hack day of sorts, really. So hack day as a concept comes from within the NHS in the UK, where what essentially happens is that you have clinicians and IT people who identify an IT-related issue, and they all come together mainly to solve that problem as such. So here, the idea is that we'll be bringing together community members, researchers, service funders, GPs to discuss all the key topics that have been identified to then see if we can come up with couple of key questions to then translate them into research ideas and projects and apply for further funding to take the work forward. And lastly, as you all would have already seen, we have a paper published which came out towards the end of last year. So thank you all for patiently listening to me. I'm going to stop sharing my screen now.